My name is Vincent Diller, and I did my presentation on evidence-based project on incentive spirometry. Now, the objectives to this presentation is to obtain key background information on incentive spirometry, learn via literature synthesis what articles say about incentive spirometry, and determine ways to incorporate the findings into everyday practice. Now an introductive to incentive spirometry, and from now on I'm going to recognize it as IS, is that it's a common practice after surgery to prevent complications. It's used to help expand lungs, improve lung hygiene, and lung health. And as you see, it is a device at the bottom of the page where the patients inhale and breathe in air, and it's a visual representation of the amount of volume that they are breathing in. The standard physician order is 10 times while the patient is awake. Not too many patients use this device. As it's ordered, it's poor patient compliance. And one of the reasons why I wanted to undertake this project is because in the ICU at Lancaster General, the nurses recently got responsibility from the respiratory department that's now the nurses' responsibility to teach the patients about IS. And the purpose of this presentation is to review, like within the last 5 years, peer-reviewed articles to determine the effectiveness of incentive spirometry, or IS, after surgery. My PICO question is: after patients are extubated, does addition of incentive spirometry therapy reduce pulmonary complications? As we know, P stands for population, and in this, the population is extubated patients, whether that was post-procedural or after respiratory distress. The I is intervention, and that is using the IS, usually 10 times per hour. The comparison is C, and that's in comparison to the standard treatment or standard therapy, which also includes cough, slow deep breathing, and early mobilization. And O for outcome is the reduction in pulmonary complications such as pneumonia, atelectasis, needing to be re-intubated. Now, for a literature search, I did the main literature search using the discovery tool from the PA College Library, and I used different filters, such as I only looked at peer-reviewed articles. I only used journals used from the past 5 years, so 2013 or earlier. The keywords that I searched in, I first typed in incentive spirometry just to see what would come up. However, that was too broad. It brought up articles that talked about the financial impact of IS. It talked about the IS use through a trach. It was just too broad. So in the search, I added the word effect because I wanted to see what the effect was of incentive spirometry, and that helps narrow the results. And I also wanted to find studies that had similar methods, and also that studied similar and evaluated similar results. And all of the trials that were studied for my articles were all after surgery. Some articles were unable to be opened because of denied access. We just didn't have the access or the program to open up the articles. And however, it was unclear whether the article could be opened or not opened from the delivery tool website. However, one article that I found was unable to be opened into the PDF file, so I had to use Google search and type in the title of the article, and I was then able to find the PDF file. So the process was quite time consuming. Now, a literature synthesis of all my 5 articles. From all five articles, it showed that IS is a standard therapy or standard practice throughout the world from post-procedure. The use of IS after surgery in all the trials were 10 times per hour while awake. However, Yazdanik was every 2 hours, so 10 times every 2 hours while awake. And Tyson and Agostini revealed that there was no improvements in lung function with IS. Now, they studied the volume of air in which a patient could expel out. They studied that it's called forced expiratory volume, and they studied that whether the patients with an IS or without an IS, if there was any improvement in the amount of air that patients could breathe out. And it's revealed that there was no improvements. And also, Agostini, Pantel, and Malik showed that there was no reduction in pulmonary complications or the length of stay with the addition of incentive spirometry in the therapy post-procedure. However, one comparison with all of the studies was that none of the studies revealed accountability for IS use. So although they wanted the patients to use it 10 times every hour, that accountability was not identified. So it's unsure whether the patients really did use it 10 times per hour or not. In contrast, Pantel was the only study performed in the United States. All other studies were throughout the world, whether in Iran or Europe. Yazdanik was the only study actually to show improvement. This study showed improvement in blood oxygenation via a blood gas on the 3rd day post-op. On the 1st and 2nd day, there was no improvement. However, on the 3rd day, there was improvement. However, it also been noted in the study that improvement in blood oxygenation by breathing exercises is temporary and also reversible after a short amount of time. So the question in this study is, how soon after the breathing exercises did they obtain the blood gas? And was it consistent throughout the study? If it was too soon, maybe it falsely showed improved blood gases. Also, this study didn't reveal any other secondary data such as complications or length of stay. Tyson and Agostini used block randomization, and Patel and Malik showed or used computerized randomization, which both are probability sampling. However, the sampling for Yazdanik was unknown. So which method did I use for the literature synthesis? I used the synthesis worksheet that we used for the assignment in week 2. It allowed me to organize the article's information into different categories like the purpose, method, participants, results, conclusions, strengths, and weaknesses. Although it was time consuming to create, once it was created, all 5 articles were then easy to view and easy to compare. Now, practice recommendations after this, after all 5 articles were revealed. One main one was that IS should not be part of standard practice, at least for lung resections, because 2 articles that are used by Malik and Agostini was that after lung resection and thoracotomies, that the use of IS did not aid in the improvement of declining pulmonary complications. This would also cause a decrease in cost for IS because there was less devices that patients would have, which would be an improvement to the hospital to save money there. But also they would need more education for the staff, as most staff only use IS for breathing exercises rather than cough, the slow deep breaths, early mobilization. This is because the IS is quick and easy for the staff to use. To conclude, healthcare providers should continue to analyze their practice. They should review their sacred cows. The sacred cows are things that we have been doing in the hospital because we've always been doing it this way. One such thing now is incentive spirometry. We've always been using it, but now we need to study why. And the IS policy should be reviewed, and the therapy should be discontinued as it has been proven to be ineffective. And here are the references that were used, all 5 articles.